I'm Bill Rossi. Like I said, I'm one of the orthopedic sports medicine docs here at Princeton Orthopedics. I want to take just a minute to thank everyone for coming and for having me here to give this lecture tonight. We're real excited about being in the area. As Steve said, we just opened up this office. We're trying to get our urgent care busier, or build a practice out here in a new footprint in this area, and we're really excited about it. So thanks for taking the time on a Thursday. Today's Thursday night. To come and spend time with us here. So I'm going to be talking about something that is near and dear to my heart. I love this topic. It's my favorite one of my favorite orthopedic surgeries to do. And I'm going to talk about it. And there's been many times I've given this lecture. And this lecture first started as when I was a fellow in my fellowship training. I was giving this to junior residents. So there's a variation, and it's morphed over the last couple of years because I've given it a few times and I've changed it for different audiences and so forth. And when I was giving this lecture, a big portion of it was very technical and surgical, from a surgical standpoint. I deleted some of it. I was going to delete it all, but I thought it would be good to keep some of it so you guys can see what we see at the time of surgery and kind of understand our approach to this problem and this injury, and how we figure out different ways to treat it, different treatment options, whether it be different grafts or different techniques and so forth. So I did take out some of the surgical techniques that I thought were a little irrelevant, but I left quite a bit just to kind of give you guys an idea of what things we talk about. And I also tried to obviously incorporate things from an athletic trainer standpoint that would be relevant to you when you see the patient on the field, to the athletic training room, to post-op if you're seeing them, trying to get them back to their sport, whatever that sport may be, things that you can kind of incorporate into that practice and communicate back to the doctor, which would be helpful to expedite an athlete's return to sport. So as a quick outline, and this is just a rough outline, an introduction into who I am and kind of where my background is and why this is an area of interest to me and other things that I do. Then go right into the anatomy of the ACL. A lot of it may be a review for you guys. It's just something that I think is important to kind of outline and review before we go into a talk on different issues. And then go through the function of the ACL as well as the risk factors for injury, common mechanisms of injury, then go over the injury statistics and the epidemiology of the injury itself. And we can't neglect common associated injuries that we see very often at the time of surgery, just because if we do, very often that very negatively impacts the outcome. So I will talk about common associated injuries and treatment options for those injuries, and then go into the surgical options for the ACL, and then the specific treatments of the injuries, like I said, and then go into a topic that is more kind of incorporate what you guys see on your end more often, is the rehab and the return to play in sport. And I did want to make this more interactive, so if you have questions, any issues, anything about the slide or anything that you see, feel free to stop me, just because it'll break things up and it'll make it a little more interesting and engaging talk. So. As I've already alluded to, I grew up in New Jersey. I'm local to this area, Metuchen, Edison area. I graduated St. Joe's in Metuchen in '01. I did my undergrad at Boston College. I went to med school at Rutgers in Newark, New Jersey Medical School. Did my residency in Manhattan at NYU, 5-year orthopedic residency, and then I did a year fellowship training in sports medicine up in Boston, where I worked with a lot of professional athletes there. And then I've been a member of the Princeton Orthopedic sports medicine team here since 2016. So just over 3 years now. My specific areas of interest, they really range from the knee to hip to shoulder, but basically athletic injuries is what I see mostly. And my main priority is getting patients back to their prior activity level, whether they're 13 years old or 70 years old. As the population ages, I mean, patients are being a lot more active until a lot later in their life than they were even 10, 15 years ago. So you see athletes of all ages. Specifically, my sports medicine training and area of interest, knee arthroscopy with ligament reconstruction, specifically ACL surgeries, like we're going to talk about today, multi-ligamentous knee injury reconstructions, meniscus surgery. I do cartilage preservation and transplant techniques, as well as hip arthroscopy, labral and repairs and femoroplasties, and then shoulder arthroscopy, meaning rotator cuff surgery or stabilization procedures. A small portion, about 15 to 20% of my practice, is also shoulder arthroplasty, meaning total shoulder replacements. I don't do knee or hip replacements, which is not going to be relevant to you guys. So just to review the basic anatomy of the knee, I know you guys know this already. There's 4 main bones around the knee joint. 3 of them make up the knee joint itself. The femur, which is the thigh bone here, the tibia, and the patella articulate to form the knee joint. The fibula, which is on the outside part here, is also a main stabilizing bone, and where multiple ligaments attach to stabilize the knee, so it's a very important area of the knee as well. The 4 main stabilizing ligaments of the knee, obviously, are the ACL, the PCL, the lateral collateral ligament, or the LCL, or commonly called the fibular collateral ligament, and then the MCL, or the medial collateral ligament. There's a lot of other stabilizing structures. These are not the only things that stabilize the knee. There are secondary stabilizers like the medial meniscus, the medial lateral meniscus, posterolateral corner, posterior medial corner, the patella tendon, IT band. So there's a number of things that go into stabilizing the knee. The ACL is just one of it. It happens to be one of the most important, but it is just one of a number of structures. So getting right into the ACL lives in the intercondylar notch, which is the area between the medial and lateral femoral condyles. It goes kind of horizontally or longitudinally across the area, and there's 2 main bundles, the anterior medial bundle as well as the posterior lateral bundle. The anterior medial bundle being the more robust bundle, that is one of the more important stabilizing bundle, has to do with a lot of pivoting stability of the knee. The overall function of the ACL, it functions really as a static as well as a dynamic stabilizer. The anterior stabilization of the anterior cruciate ligament is obvious. It prevents the anterior translation of the tibia. Its most crucial role, though, is also a pivoting stabilizer. It is the primary stabilizing ligament in any pivoting sport. Anytime there's a sport that is associated with a quick change in directions, like soccer, skiing, anything, basketball, football, anything like that, the ACL is crucial. Like I said, other secondary stablers that can back up and help the ACL are things like the meniscus, the patellar IT band, tibial slope, which is basically the slope of the tibia, how flat the top of the tibia is, can also help stabilize the knee. So these are all things that we consider when going into ACL reconstructive surgery. Now, I have a couple slides here about risk factors. This, over the last 10, 15 years, preventative medicine has become huge, and we're really trying to prevent these injuries before they happen. There's been a lot of research on this and a lot of studies, a lot of identified risk factors. The highest, really the most discussed risk factors are the sport and the type of sport that is. Any pivoting sport is going to be a huge risk factor for an ACL tear, and these pivoting sports I kind of already alluded to were soccer, football, and basketball. These really are the 3 that are most prominently found to have ACL injuries in the United States. Now, if you expand that group to include Europe, then rugby is a huge part of that as well. Lacrosse and tennis. Tennis is, I don't see many tennis ACL injuries, but lacrosse is also a very highly impacted sport of ACL injuries. Lower risk sports are the sports that are non-pivoting. So running straight in line, baseball, softball, track, swimming, those kind of sports. Snowboarding, believe it or not, is not as high of an issue as skiing because your feet are planted. There's not as much pivoting associated with it as there is skiing. Females are at a very much higher risk of ACL injuries than males, and there's been a lot of studies into that. A lot of it has to do with what this ratio we call knee flexion or to knee extension, has to do with the size of the hamstring. Females have the smaller hamstring muscle in relation to the quadriceps than the males, and we'll go into the mechanism behind that. But basically the overpowering of the quadriceps, which is the muscle in the front, obviously pulling the tibia anteriorly, isn't counteracted well enough from by the hamstrings, and it decreases this ratio. And what it does is it puts them at increased risk of rupture of the ACL. So when we get into injury prevention programs, which is something that hopefully all the athletic trainers are getting involved in, a strong focus on that is going to have to do with knee flexion strength and hamstring strength and recruitment to offset this this ratio. Also, things like greater BMI, body mass index, or weak hip abductors can be associated with non-contact ACL injuries. Specifically, again, this will be discussed later, hip abductors being weakened allow the hip adductors to overpower that, and they kind of bring the knee into internal rotation and a slight valgus load, and that applies a force, a torsional force to the ACL that can't be offset very well, and it puts an athlete at an increased risk of non-contact ACL injuries, which is something that is addressed in new injury prevention programs that are being outlined. And then also playing surface. A couple of years ago, this had a huge amount of research into it to figure out what was the better surface to play on. We did find that typically turf, there's a much higher risk of ACL and non-contact type injuries, and that just has to do with versus natural grass, and that has to do really with the traction that the shoes and the cleats get on the turf, which is much more. There's a lot more friction than a natural grass. So there's a lot more torque and pivoting force that goes through the ligaments when athletes change directions quickly. Then you look at specific risk factors that, because you ask yourself, we're thinking about preventative medicine, how can we help prevent these injuries from happening in the preseason, during the season, things like that. And there are things that you can't modify: patient's sex, family history, anatomic structure, biomechanics of their lower extremities, things, hormonal issues, things like that, put patients at increased risk. But there are a number of issues that you can modify. And these, specifically, these 4 down here, which I circled, really are crucial in any injury prevention program that can be first addressed and at least brought up with the coaches and the athletes at the athletic trainer level. And that is experience of pre-injury level in competition. The more experienced an athlete is, the more pronounced they quickly change directions, and they have better proprioception to do so and protect themselves. Skill and conditioning takes a huge role in that. Muscle strength and balance, which is really what the whole heart of injury prevention programs are, and then the pattern of movement during high-risk activities. All of this can be modifiable. There's a lot higher percentage of low-level athletes that sustain ACL injuries than the high-level athletes, and this really is why. And just to touch one more time on the sex differences, females are a much higher risk of ACL injuries, and like I alluded to before, that really is because of the hamstring strength compared to the quadriceps. Studies have looked at it. It's anywhere from 3 to 5 times more likely for females to sustain ACL injuries compared to their counterparts. And the mechanism of that, really, like I alluded to, is the quad contraction, which you can see here. The quad's in the front. It can pull the tibia anteriorly, and the corresponding antagonist, which is the hamstring, if it's not in appropriate condition, or it can't offset this counter pull appropriately, it puts the ACL, which is pictured here, at risk of rupture. So resistance training really should be geared at all muscles around the knee, but should also have a strong focus on hamstring strengthening. And if you look at pro athletes in the athletic training room nowadays, it used to be all about quadriceps and so forth. Their hamstrings are becoming a much bigger part of their preseason training. And these are really, the only reason I bring this up is because these are findings that have been crucial to these injury prevention programs, and that should be targeted during the resistance training to help minimize this risk and better set this ratio. So mechanism of injury, there's 2 mechanisms: contact versus non-contact. Contact is really pictured up here, where football players are very commonly associated with this. A person falls on the outside lateral aspect of the knee, or they take a hit right there, the knee twists, and you can get an ACL tear. These are more commonly also associated with multi-leg injuries, like an MCL. This athlete here has an ACL and is going to have an MCL injury as well. You can tell just by the way the knee is. Same thing here. These, however, are not the more common injuries mechanism. The most common injury mechanism for an ACL is a non-contact. An athlete who's running down the field, trying to catch a pass or so forth, and quickly changes directions here. No one has touched them, no one has had made contact, and their ACL ruptures. And that's a quick pivoting that the balance of the knee cannot quickly offset the force that the ACL experiences, and the knee ruptures. That can account for, depending on what research you read, for about 70% of the ACL injuries. So it's really, and most of these non-contact injuries is what the injury prevention programs kind of target to try and prevent or minimize their occurrence. So, you may say, so what? This is one ligament in the knee. You just said there's a ton of ligaments. There's a lot of different areas of focus that we can have about the knee to help maintain a patient or an athlete on the field. Why is the ACL so important? Well, it's so important because it's so commonly injured. It is the second most commonly injured ligament around the knee after the MCL, which I'm sure most of you know. The MCL is usually not treated operatively. It's a grade 1, grade 2 sprain, treated in a brace and some physical therapy and rehab, and they can get back to high-level sports and pivoting sports with good reliability. That being said, the ACL is not the same story. It is the most common ligament in the body requiring surgery, and that's not just in the knee. That's throughout the shoulder, the hip, the ankle, the elbow, everywhere. It's a very commonly infected injury that needs surgery. And 70% of these are due from athletic participation. The other 30% come from falls, mechanical trip and falls, motor vehicle accidents, things like that. The incidence of these ACLs, depending on what you read again and when the study was done, it's about 1 in 1,750 persons, which is about anywhere from 200 to 300,000 a year in the United States. Common ages. Now this is now, I'm seeing patients much older than this now getting ACL tears. I mean, I just saw someone today, 61, getting an ACL tear, was playing racquetball and twisted his knee. So it's a very common injury. The typical age range is 15 to 40 or 45. This is now expanding higher and higher. And approximately, as of 2016, approximately 200,000 ACL reconstructions were done each year. That's a huge, as you can imagine, a huge direct cost, about $3 billion to our healthcare system throughout the year, and that's a direct cost of hospital stays, equipment, anesthesia, things like that. But really the issue is the indirect cost, which we can't calculate. And by an indirect cost, I mean athletes in their senior year matriculating to college looking for scholarships, they blow out their knee, get an ACL tear, their chance of a scholarship goes down dramatically. You have, when I worked with these high-level athletes, an ACL tear, any kind of injury like this is devastating to them because it can cost them a lot of money and a lot of opportunity. Not to mention those patients who are no longer in high school or college, who are kind of weekend warriors who are working. They take time off of work because of this injury. They lose a lot of income because of it. So there is a pronounced indirect cost that we can't even begin to assess the number of. So it's a very relevant, it's a little ligament, but it's a very relevant ligament. History, typically the athlete describes hearing or feeling a pop. They felt the knee shifts. That's usually with a non-contact type injury or a quick change in direction where something happened, they felt a pop, their knee shift, and they went down. There's immediate pain and swelling, a large effusion. Athletes who are playing soccer, football, they say they felt their knee shift or pop and they can get up and play the rest of the game. They did not tear their ACL. ACLs are immediate, blown up knee that they can't activate their quads, they can't put any weight on it, they can't finish the game. Like I said, difficulty walking and bearing weight, unable to complete the game. Other injuries that can also be associated, like I said, that patient who felt the pop but can play the rest of the game, MCL sprains, other LCL sprains, or maybe a patella subluxation. Those are things that should be on our mind when we approach an athlete down on the field. But really, what we're trying to rule out first is the ACL tear. So, the games I've covered, it's always the athletic trainer that runs out on the field when an athlete is down. These are tests that should be done, either right there on the field or if they can carry it off to the sideline, that everyone should be familiar with, testing the ACL. Do you guys all know, I'm assuming you guys all know this test. So the Lockman test and the anterior drawer are very easy to do. Really, the Lockman is really my workhorse for ACL testing. Typically, when it's an acute injury and you have an athlete down on the field that you bring to the sideline, you get one chance to do a Lockman before they start guarding, and then it feels stable because you do it one time, tell them to relax, and you do it, you can feel a good shift of the ACL, and you say that's torn, you try it again, and they're guarded. You're not getting a good ACL again, an ACL test again on any of these. So you really should have a good idea on how to do these well because you're going to get that one chance to do it, and then you're not going to have a good test going forward. And that just has to do with the athlete's pain. They're in a lot of pain that one time, they're not expecting it, and you get a good test, and then they're going to guard up and not be able to do it again. What we're looking at on the MRI when we see them in the office and send them for an MRI, these are really classic findings of ACL tear. This is a normal knee. The femur here, the tibia, this is an ACL coming up this way. Nice, good signal all throughout the ACL, no tearing in there. You even see portions of the PCL coming up here. If we were to rotate the slice a little more, you'd see the PCL attach up here. This middle one is the classic ACL rupture. Normal ACL, there's nothing here. There's no black line here. there's just the ACL exploded there. That's a full thickness tear here. A lot of times, what we also see is this bone bruising here, which is pathognomonic for ACL injuries. You see this bone bruising. This pattern of bone bruising can't occur without an ACL being torn. So, if the radiologist read as possible partial ACL tear, maybe sprain but intact fibers, and you see this, it's an incorrect read. That the ACL is torn, it's not functioning. This cannot happen without an ACL being torn.
That's on the posterior side.
Yeah, so this is that's a good question. This is the posterolateral side. So this is the lateral tibia plateau, and the back part of the knee, the front part of the knee is over here. So you get basically a corresponding kissing lesion on the posterolateral tibia and the anterolateral femur. And in order for these two parts to make contact, the ACL has to be torn. Other concomitant injuries, which you talked about, meniscal injuries. Lateral meniscus is the most common in acute injuries. Medial meniscus still occur. Medial meniscus tears still occur at the time of injury, but they are more common when there's prolonged time to surgery. When you have a chronic ACL tear, the patient is more likely to also develop a medial meniscus injury at that time. Meniscal root tears, which you see some evidence of it here. These are very crucial to be identified at the time of surgery. These and what we call ramp lesions are also very common at the time of ACL injuries. And as surgeons and so forth, these are tough to diagnose on an MRI, so it's something we always got to be looking for at the time of surgery. Cartilage injuries, which I'll show you some pictures of that, also need to be addressed. They should be able to be seen on MRI, so we should, from a surgical standpoint, we should be prepared to deal with them. However, whenever I do an ACL, I always have things available in the room in case there's a cartilage injury that just didn't get picked up on the MRI, and we need to be able to deal with it at that time. And then multi-lig knee injuries are really a different animal altogether. They are tough to deal with. They're very commonly missed. Really, they are something that need to be addressed and identified preoperatively, because it will change the course of surgery and the overall rehab. And it will dramatically, which we'll talk about, decrease the overall outcome of the patient if these are missed and not addressed. Identification, like I said, identification of concomitant injuries is crucial. Physical exam really is key to dealing with or identifying a lot of these. The MRI is very helpful, but for instance, the multiligamentous knee injuries sometimes are not as easily identified when they're subtle on the MRI because of a lot of increased swelling. So they may just look like a sprain, but you don't really notice it's torn. And the physical exam is key to assess stability other than the ACL, or in addition to the ACL. Failure to identify these injuries, like I said, will lead to decreased success rates, such as failure to return to sport, continue pain, and have a very high risk of re-rupture of the ACL surgery that you do. An increase in their revision. What I tell patients, most importantly, when you're dealing with an ACL, primary ACL surgery, when done well in the right patient with the right rehab, the success rate on average is about 90–95%. And success rate is dependent on how someone defines success. But in order to get back to a high level of sport and get them back on the field, it's about 90%. You can do that when done well with the right rehab. Once you go through a revision ACL surgery, that success rate goes down to 50–70%. I see a lot of revisions from other docs, and I tell them straight out, the first time around, the success rate is up. Second time around, sometimes even the third time around, we're not talking about getting you back to sports. We're talking about giving you a stabilized knee that you can walk and trust that's not going to buckle on you. Yeah.
So for a high school athlete who has revision, what are you doing as the surgeon are you prolonging the time that you clear them? Are you saying where normal, in high school realm it's 9 months, NFL 10 months, but are you as a surgeon saying not before a year or?
No. The first thing I do as a surgeon when I see anyone, whether it's a 15, 16-year-old high school athlete or a 40-year-old weekend warrior, if they've ruptured their ACL, I want to know what graft was used, and we'll go into that. We need to diagnose other issues, making sure these concomitant injuries that I just talked about last slide weren't missed, because very often that's why it failed. And then we need to do some advanced imaging, like a CT scan or MRI, to assess how the ACL was done, where the tunnel position is, and so forth. Sometimes it's just a matter of, sometimes it's bad luck, but other times it's malposition of the tunnels. It's a poor option of a graft that was used, and if you just change those things and treat it like a primary ACL, you can increase the success rate. I don't have any strict, revisions take 10 months to a year to get back to pivoting sports. Everyone, and I'll go over my rehab, at 6 months starts pivoting. They're not cleared to get back to sports till a minimum of 8 months, most are 9 months. And there are times when in revision settings, that 9 months is not happening. At 9 months, they're not ready yet, and they end up taking 10 or 11 months. But it's not a go-to revision. It takes 11, 12 months. First thing we see with revisions, we want to find out why it failed. Treatment options, non-operative treatment. There's always a choice of non-operative treatment. In a young athlete who does pivoting sports, this is not a good option. You can't do a lot of these sports without an ACL. These are really for lower demand patients. Athletes don't really have much of a role in non-operative treatment. If they're inline athletes that want to just run and do track, maybe they can get back to that. But any kind of pivoting, turning, hurdlers, anything like that, they need their ACL. When you're choosing non-operative treatment, you're accepting a lower functionality. You're trying to get a pain-free knee that can have them run in line. But you're really not doing any pivoting. These are not for high school athletes. These are for the 40, 45-year-old weekend warriors who tear their ACL and they say, do I really need to be playing a pickup basketball game, five times a week? And they may choose to not have a surgery, just do some physical therapy and get back to things on day-to-day activities, but not pivoting sports. Operative treatment. This is the crux of the talk, and I modified this a lot. I took a lot out, but this is kind of a little history on how we used to approach, as orthopedic surgeons, used to approach this issue and how it's kind of evolved throughout the years. ACL reconstruction versus repair is the first, I still get asked, why do you need to reconstruct this? Why can't you just repair it? We tried that in the 60s, 70s, and even early 80s, they tried repairing ACLs. They didn't do well. An ACL, a lot of these tears are, like I said, from an increased torque on the ACL ligament, and the stretching occurs, and then the ACL pops. And you saw that one MRI that looked like there was no substance left. If you're trying to repair that, you're basically trying to sew wet spaghetti back to wet spaghetti. It's not gonna work very well. And it's also bathed in synovial fluid, which is joint fluid, which makes the healing potential almost zero. So it's really not a good option. There are certain studies now showing in younger patients with specific type tears, you can repair it and the outcomes are getting better. But still the gold standard since the 80s or 90s, 80s and 90s has been to reconstruct the ACL. And that's, this is a meta-analysis that was done back in 2014 looking at this, because the question kept coming up even 20 years after it became the gold standard, like why are we, do we really have to treat these? Can we delay this? Really, the heart of this is looking at a meta-analysis is looking at the outcomes of non-operative treatment and comparing them to operative treatment. And this study here, which was published in AJSM in 2014, looked at over 200 patients, and they compared operative and non-operative treatment. And what they found was really remarkable. And it was expected, but it's really very evident as to why they need to be reconstructed. Post-treatment laxity, pathologic laxity, meaning leading to other issues and recurrent tears, after an ACL reconstruction is 13%. This number is based on reconstructions done in the early 2000s. Our techniques have changed. This number is now down to 6 to 7%, but still much different than the non-operative pathologic laxity, which is up to 75%. As far as meniscal tears, people who have ACL reconstructive surgeries, their post-operative occurrence of meniscal tears in the future is about 4%, whereas if they don't have surgery, and they don't have a meniscal tear at the time of injury, at long-term follow-up, about 35% of them will have meniscus tears, which is just kind of indicating the relevance and the importance of reconstructing the ACL. And this is really the biggest impactor here. Return to previous sport. Returning an athlete to a high-level pivoting sport from an ACL surgery, although success rate is 90-95%, returning them to that level of sport, and when you look at the numbers, it's about 80-85% when they have surgery. When they're treated non-operatively, none of those patients can get back to that. That's how crucial the ACL is in pivoting and pivoting athletes. So a good part of kind of breakthrough here is where physical therapists and athletic trainers really can come into play here, is with the ACL prehab. This is something that we do on all ACL surgeries now. It used to be, and this was really because studies looked at timing of ACL injury to surgery, where if they did it before 3 to 4 weeks, patients were having a lot of what we call arthrofibrosis, stiffness in the knee postoperative, and they had to have second surgeries to break up the scar tissues and get their motion back. So what we started doing and started seeing is that the longer you wait, the patient gets their motion back and they're ready for surgery, but they're also putting themselves at risk of further injuries, like these meniscal injuries that weren't there at the time of injury, can have meniscus tears when they get to the OR. So we really want to minimize the time as safely as we can without putting them at risk of further injury to the knee or risk of arthrofibrosis or stiffness in the knee after surgery. And this is where the ACL prehab comes into play. It should be, I initiate it as soon as I see the patient. If a patient has an ACL tear in a game on a Saturday and I see them in the office on Monday, they're in ACL prehab on Tuesday. They are mobilizing that joint, minimizing the swelling and reactivating the quad so they can get we can get these athletes back to the OR very quickly. And that's done in the athletic training room as well as with physical therapists. And I have trainers that I talk to that I know of, the school trainers, that if a student comes in with an ACL tear, I give them a script for physical therapy, but then I also call their trainer and say, I'm going to, he's going to be in school, he's going to start physical therapy after school, but if he has any time throughout the day, if you can get down to the athletic training room and you can start working on joint mobilization, that will help him get to the OR quicker. There are new studies that have looked into this, and this number of 3.5 weeks, 3 to 4 weeks of waiting is no longer mandatory. It really has to do with the optimization of the joint. So whether that happens at 1 week, 2 weeks, or 6 weeks. I've had to wait 6 weeks sometimes to get an athlete back into the OR because their swelling was just so bad. But if their swelling comes down, their motion comes back, and their quads are reactivated within a week or two, you can get them into surgery reliably, and there's evidence to support it that the risk of stiffness afterwards, arthrofibrosis, is minimal. And like I said, it can cause less damage to the knee because there's less time from the time of injury to surgery. Current management, like I said, ACL is a reconstruction. It's an arthroscopic procedure. There is an incision made from graft harvest site if we're using autograft or a patient's own tissue, which is something we should do in patients under the age of 40. Over the age of 40, you can use cadaver tissue with a very comparable failure rate, but below the age of 40, so certainly any high school athletes should not be getting allograft tissue for an ACL reconstruction. They get allograft for MPFL, other ligaments reconstruction around the knee, but the ACL has a significantly higher failure rate because there's a lot of torque that goes through there when you use an allograft in a young patient. And there's different graft sources, and like I said, this was kind of geared more at training orthopedic surgeons, but I still thought it was relevant to keep. There's really 3 main graft choices that we utilize from autografts, and it's BTB or bone patella tendon, hamstring, or quadriceps. The 2 most common by far are the BTB and the hamstring, which we'll talk about. Just to quickly reiterate what we said, cadaver tissue are for patients older than 40. They're not for anyone younger, never in young athletes. In revision settings sometimes, but even now, if a young athlete tears their ACL and they had a BTB or a patella tendon bone autograft that failed, before using an allograft or cadaver tissue, I'll take the graft from the other knee. Because it's just a better graft for that patient. So it really should not be used in young athletes on only rare occasions. When it's autograft used, the patient's own tissue, it's all other instances really. Young patient, contact athlete, age less than 40. Physiologic age less than 40. I have done many autografts in patients 45, 46 who are physiologically on an activity level much younger. They're doing things that 25 and 26-year-olds are doing. We're putting autografts in them. Really, the option of the graft is surgeon's preference. Hamstring and patella tendon are the 2 most commonly utilized grafts. There are studies that support both. There are pros and cons to both. If you ask me, my preference is BTB because I think it's the best graft. But if you ask other surgeons in our group, they think hamstring is the best graft. So there's a time and a place for both. But overall, studies have shown that the both grafts are acceptable. To go through some of the pros and cons, people who are proponents for hamstring say that it's a faster harvest site, less risk of anterior knee pain. I do probably 90% patella tendon bone. It is not a faster, I'm much faster at harvesting the patella tendon than I am in the hamstring, and that's just because that's my preference and what I do more of. So a lot of it is surgeon preference. Cons to both as far as residual hamstring weakness, there's a lot of studies that look at that. You should not, if hamstring weakness is a concern, hamstring reconstruction should not be done in hurdlers or any kind of long jumpers where they require that explosion, that push-off strength, because there is very subtle changes in that. And most athletes, they don't notice it and it doesn't impact them, but these specific athletes can note a difference. There's also some very large database studies out of Europe and even out of California that for some reason have found higher infection rate and a slightly higher failure rate in the hamstring use. Don't really understand, and we don't really know why. It's just a couple of studies that have shown that, but that is out there in the literature too. As far as the cons for patella tendon, people always say anterior knee pain, so I'm hard pressed to do that. I know it's not high school athletes that you have to worry about, but these weekend warriors, plumbers, electricians who are on their knees for their livelihood and their work, I'd be worried about doing these patella tendon grafts in them. And a bigger incision, like I said, I do so much of this. I do this through a pretty small incision. The incision I use for both of these grafts is very similar, so I don't really think that's an appropriate con. Like I said, I've already told you what my preference is, BTB, bone patella tendon. I think it's a faster graft incorporation and immediate fixation because you get 2 big bone plugs and 2 big screws and you fix it into place as opposed to a screw and a button or however you fix you choose to fix the soft tissue. The main reason that it's my gold standard, it's the gold standard in the NFL. So if it's good enough for them, it's good enough for my patients and my athletes. I've actually, when I was doing entrance exams on NFL players, if they had a hamstring autograft ACL surgery, that counted against them. Just because of the pivoting and so forth, it's felt that the BTB is a better graft for that. These are just some photos of what BTB reconstruction ACL looks like. An artist's description of it, the graft coming in through the medial tibia. There's a drill hole here. We use a reamer, and then another reamer makes a tunnel in the femur. We fix it into place here. I usually use 2 screws, one in the femur and one in the tibia. There's different screw options, metal versus non-metal. I don't use metal, but you can use metal. The studies are the same on both. And these, like I said, there's been advancements. The studies that I quoted earlier as far as success rate, at the 14% of residual pathologic laxity, a lot of that was found to have to do with tunnel malposition, and that's from surgical techniques, which we've changed over the last 10, 15 years and started a more horizontal tunnel, which is beyond the scope of this, but this slide is just to show you that there's constantly evolving techniques in surgery to optimize outcome, and the numbers that are in the literature now are numbers from techniques and surgeries that were done 5, 10 years ago, and they're constantly advancing. So the numbers now should be ideally even better. Another slide just looking at different types of tunnel drilling. Everyone likes to see photos, so this is an intraop photo of one of my ACL reconstructions. You can see this is what we call the empty wall sign. This is the lateral femoral, this is the notch in here. This is the lateral femur. This is the stump of the ACL. It's supposed to be coming up and attaching here. There's nothing attached here. This is after we drill a tunnel down here in the tibia and drill a tunnel in the femur. We pass a suture up, and this is the graft coming in over here and a new ACL going into place here. This is another intraop photos of mine. This is the intercolumnar notch again. This is the ACL. It's supposed to be coming up here and attaching here. There's nothing much attached here. You even see, I took this picture here because I thought it was a great picture of the anteromedial bundle. We talked about the 2 bundles of the ACL, anteromedial bundle being the more significant and more important bundle. And this is, obviously, you can see it's not attached at all to where it should be. So this is the main stabilizing ligament for pivoting that is just not functioning anymore. So what we do is we clean all of this tissue out, which is here. This is the PCL still intact, but where the previous ACL is no longer there. We drill our tunnels, and we pass a new graft and ACL and fix it in. This is a biocomposite screw that I use that in 12 to 18 months turns into bone, but it's basically a plastic screw, and it fixes the graft into position, and you get a new ACL there. Are there any questions before we go into concomitant injuries and other things that we see at the time of surgery? Okay. So I chose to focus on 3 different injuries that we see very often at the time of ACL surgeries. The most common being the meniscus tear, which, anytime I see a patient that had an ACL surgery years ago or had an ACL surgery recently and is coming in with new pain, the first question I ask is, what graft did they use, and was there also a meniscus tear? Because the meniscus tears, being present at the time of surgery, have been shown to decrease the overall outcome of these surgeries. So that's the first thing I ask. that has been found when the meniscus tears are there, that there's a negative impact on return to sports. The risk of reoperation goes up. The risk of arthritis, that's still questionable whether or not that's impacted by meniscus tears. That's likely more impacted just by the ACL injury itself, which new research is proving. And like I said previously, lateral meniscus injuries are much more common at the time of acute injury. Repair versus meniscectomy, which we'll go into in the next slide. They can change the postoperative rehab protocol. We repair them. I'll show you pictures on the next slide where we put sutures across this and try and get it back to heal to itself, where we maintain the patient's own meniscus tissue, don't remove any. That will change postoperative protocols and restrictions that a patient has in the athletic training room and with the physical therapist. It shouldn't change overall time to return to sport, but it will change specifically the first 4 to 6 weeks after surgery. So whenever if you see these patients in the athletic training room, it's important to know if their meniscus was involved. Was it just removed, the torn part removed, or was it repaired? And a lot of that has to do with the restrictions that are associated with that. Like I said, meniscectomies versus meniscal repairs. Meniscectomy is basically removing the tissue, which is being shown here. We remove a torn part with basically a biter, just kind of contour it and remove it. Or we can do a meniscal repair. There's different techniques, which is I'm not going to really go into, but we repair basically by putting sutures across. These are vertical mattress sutures going across a tear in the posterior horn of the medial meniscus. You can see the meniscus here. This is the bottom part of the femur, the top part of the tibia. Meniscus lives right in between, and the tear was back in here, and the sutures are going across here, fixing it into position. So no meniscus tissue was removed here. And then as far as the results for meniscal repairs, they have a relatively high failure rate, 14% failure rate. A lot of it has to do with the type of tear and where the tear location is, because the blood flow to that area is crucial in getting it to heal. There's been a lot of studies that look at the outcome of meniscal repairs at the time of ACL surgery, and what we have found is that the reoperation rate when a repair is undertaken is a lot higher, because these don't always heal. So the ACL may do great, but the patient may still have pain. You get an MRI afterwards, and it shows that the meniscus didn't heal right. You have to go back in and clean it out. So you may say, why do you even repair it? Just remove it if it's not a big tear, and you don't have to worry about this. Well, overall, although the reoperation rates are higher, the overall improvement in outcome and pain scores when these heal is much, much better. So it's really worth, if you have a tear that is amenable to repair, it's really in the athlete's best interest to repair it. And then meniscal allograft transplants it's something that is an option for large tears that have been attempted to repair, that have failed, and that we can go back and actually transplant a meniscus. That's a talk in and of itself. It's a very complex procedure, but it's something that can be done in those instances. Cartilage injury, this is something that we see quite a bit of at the time of ACL surgery. Most of the time we're ready for it. We see it on the MRI, and we're ready and can prepare for it at the time of surgery. There are times that these lesions, which you see here and here, are small. They may get missed on the MRI, and the MRI may jump over them. Or you just may be focusing on the ACL tear and not notice that there's a small cartilage injury. When you get in there, it's a lot worse. You have to be prepared for them. And what I do is I have preferred treatment options for osteochondral lesions or cartilage injuries when I'm aware of them, but I also have something in the room every time I do an ACL in case something was missed on the MRI. I can address it and get the patient back to rehab appropriately with that. So I have the instruments there for everything. But again, this also changes the postoperative protocol. Oftentimes ACL surgeries, patients can put weight on it right away. With a cartilage injury, they're non-weight bearing afterwards, so it changes the protocol quite a bit. And these are just some intraoperative pictures of patients of mine dealing with cartilage injuries. Like I said, there's the timing of the treatment really depends on the surgical plan when you're doing it. If they're being done at the time of the ACL surgery, it limits what your options are. If you want to address the ACL surgery first and then come back at a later time, you can have a lot more options that way, which sometimes is what I do. And then you can start talking about cartilage osteochondral allograft transplants, which is done here. You can basically remount the part, just drill out the part that is defected and damaged, and basically from a cadaver condyle, you perfectly match this and put a plug in there, and fresh allograft, and it heals in around it, and it's normal hyaline cartilage, or hyaline articular cartilage that heals back in. Other procedures that we're doing now, the MACI or matrix-induced chondrocyte implant. You can see here, I use them more for patellar lesions that are tough to get a graft match, because these have to be matched to the size of the patient's condyle. So it's a little more complex to do that on the patella. So I use this malleable kind of collagen bilayer to put on here, and it helps regrow cartilage cells. Outcome and pain scores are much improved at long-term follow-up, and that's beyond 10 years when these procedures are done and not ignored at the time of surgery. There are often patients who have their ACL surgeries done, and I see them because they're still in pain. And I said, well, did you have any other issues? They said I had cartilage damage, but there was nothing that could be done, and they were just neglected for a couple of years, and they're still in pain, and that's because these were not fully addressed at the time of surgery. Concomitant injuries, like I said, going into the third and final one that I'm going to talk about is really the multi-leg knee injuries, which in a revision setting, when I get revision sent to me, this is the thing I'm worried most about, is missing another ligament injury at the time of surgery, not having it addressed, and that's why the ACL fails. You can do the most perfect ACL surgery in the world, but if you have an LCL or post-collateral corner injury that was missed, that ACL is going to fail, because there's too much tension on it. It's not well balanced, and as soon as they get back to pivoting or anything, that ACL is going to rupture. And oftentimes, if it's not picked up the second time around by another surgeon, and they do another ACL surgery, that's going to fail unless the underlying multi-leg injury is addressed. And the way we do that, obviously, first is with MRI. This is showing an MRI of a grade 1 MCL sprain, and these are the different grades. And I put these here just because the MCL is the most common thing that's really the most common injury that's seen on the field and in the athletic training room. Grades 1 and 2 are treated without surgery, and they're the 90% of the MCL tears. Grade 3 is a little more problematic and sometimes needs to be addressed. But this is a grade 1 sprain of the MCL. This is the medial collateral ligament. It's intact. You can see it all the way through, attaching or originating in the medial femoral condyle, attaching all the medial plateau, superficially up here by the joint, and then deep here on the distal tibia. The sprain is the increased signal around it. So this is a grade 1 sprain. It's gonna be painful when you load it, but it's gonna have good stability and good tension on it. Post-collateral corner injuries, you can see here, these are x-rays that on one of my patients that I got a stress view of to see why they were sent to me for revision, why their ACL never healed. And you can see the gapping here when you stress the knee under x-ray. This should not widen this much. This means the whole posterolateral corner, which is a structure of multiple ligaments here, has been torn and just was missed. These are really big issues to deal with. They can make the surgery much more complex. It's a much bigger incision. It's no longer arthroscopic. The ACL portion is, but the other part is an open procedure. And a lot of that has to do with the anatomy around the knee. Is very complex and dangerous to be done through little incisions. People have tried doing them through little incisions, and you can get peroneal nerve injuries and foot drops, and you do a great ligament reconstruction, but they can't lift their foot. The athlete's not getting back. Yes? Yes. Yeah, you compare it. That's a good question. So you do it bilaterally, you compare it. I do it at 30 degrees, and I try. It's not a perfect science because it's me putting a force there that I'm trying to duplicate the force on the right knee and the left knee. So I put a pillow under the knee. I keep the flexion angle the same. I keep the X-ray beam in the same spot, and I try and put the same force on both sides, and then I measure it. This I know just by looking at it. It's blown. There are some that are not this obvious, where the condyle is down here, and it measures 6 millimeters in gapping. But if you compare it to the other side only opens 2 millimeters. That's a 4 millimeter gap. That's a big deal. So it's definitely compared to the other side. All the studies that have shown that, only reproducibility comes when you compare it to the other side. And this is just going over this is pictures of an open posterolateral corner reconstruction. It is a big incision. You find the nerve, put tunnels. These are the tunnels. This is the way I do it. An anatomic reconstruction with 2 separate grafts and really 4 tunnels. 2 here in the femur, 1 in the fibula, and then 1 in the tibia. That's in addition to the 2 tunnels for the ACL. So this is a big reconstructive surgery where you're putting 6 tunnels in a kid's knee. So it really is a complex surgery, and one that if you miss the ACL that you do, regardless of how good it is, it's doomed to fail. So that was more the surgical technical standpoint of it, and kind of the approach that orthopedic surgeons take to make sure things aren't missed, just so the athletic trainers have a better sense of what we go through, and you have a better understanding of the surgical decisions, this is where a lot of stuff can come in, and you'll see, and we'll be able to be helpful to get feedback on. I'd be interested to see what you guys have seen in the athletic training room on your end. This is a standard postoperative rehab protocol that I use. A lot of these are modifiable depending on what was done at the time of surgery and what the condition the knee was in. My autografts, which are the patient's own tissue, I let them put weight on it right away. I unlock the brace once the nerve block wears off, so postoperative day 1, I let them start putting weight on it with crutches. And this is variable, 4 weeks. They can really come off crutches in like 2 weeks. I usually keep them on 4 weeks to slow them down. I don't want them doing too much. And then the brace, I have here 6 weeks, but as soon as they can straight leg raise and their quad is reactivated where they don't have an extensor lag, I let them come out of the brace. It's very rarely before 4 weeks, and it's very rarely beyond 6 weeks. In all my paperwork I say 6 weeks, but we reassess things at 4 weeks, and sometimes they come out of the brace a little earlier. I start range of motion right away because what we don't want is a patient to get stiff. I do use a CPM machine to have them passively move the knee. Whether or not that does much, it makes me feel better. I don't. As far as I know, there's no studies that show that postoperative ACL motion is better with using a CPM. But and then I start physical therapy, whether it's with a physical therapist or if it's an athletic trainer that I know and I trust will abide by certain restrictions. I let them start it, in school, in the athletic training room, just to mobilize that joint and start reactivating the quad. Interval running starts at 3 months. I don't let them start sooner than that. And agility drills, like I said, agility drills and pivoting, I don't let them start until 6 months, and that's after I put them in a functional ACL brace. I wait 6 months for that with the plan to return to play. I say 8 to 9 months because when you tell an athlete 9 months, they get very upset. But I say 8 months, but very, very few times a patient's ready by 8 months. 9 months has been the common return to play. It used to be a big reason why people used BTBs initially was saying that you can get them back at 6 months to everything. And we were doing that, and the failure rates were going up. Andrews did a study that looked at this, and the closer to 9 months that they got from the surgery, that failure rate went down, and it was his patients. So it was the same surgeon doing, or the same fellows doing the surgery. So the technique was the same, and the failure rate when he started pushing them out to 9 months went down considerably with the same graft, the same technique. So we try and get them as close to 9 months as possible. Now, what goes into that is where a lot of athletic trainers and physical therapists come into play, and it's really dynamics strengthening and testing. Quadricep strengthening is key. Quad circumference used to be what a lot of people talked about. They still talk about it, but it really comes down to proprioception and muscle balance and retraining. These are some pictures of big risk factors for recurrent ACL tears, or a patient is not ready to get back on the field yet. This is called dynamic valgus, and a patient jumps up and lands. This is how they should be landing. This patient has a balanced knee with good hip abductors that are offsetting the pull of the adductors. This patient, it's the same patient, just different time periods. This patient does not have a balanced knee yet. The hip abductors are weak. They're being overpulled by the adductors, and they're pulling the knee into valgus and slight internal rotation. And that knee, if you return that player back to a pivoting sport at that point, they're at a tremendously higher risk of re-rupture. So this really is what I go through, and a lot of times, it's not that I get arguments in the office with parents. It's usually the parents about getting them back onto the field. Oh, well, Dr. Andrews said he can get back in 6 months. Well, actually, that's not true. He does 9 months, and NFL players, pro athletes are going more towards the 9 months. But he said, well, other people have done it 6 months. Well, okay, well, let me see him jump, and I'll have him jump in the office and land. And I'll show them, and I'll show them that when they land like this. They're not ready to get back. If you can send them back and not listen to me, we're going to be talking about this in a couple of weeks when he re-tears his ACL, and he's going to be out the whole, a year and a half then, as opposed to 9 months. And they typically back off. But this is what I focus mostly on. And then if there's ever any question, I order functional sports assessment testing, and that is sports specific. That's done by physical therapists. I don't know, do you guys, I don't think the equipment in the athletic training room will have any of this stuff here for functional assessment tests, right? Yeah. Do you? Okay. Okay, that's good. That's good to know. So then that would be something that could be done in the athletic training room as well. And really to try and tie it up and kind of bring the athletic trainers into it and what role they can play in this, it really comes to injury prevention and preventative medicine. And this is where a ton of research has been done over the last 20 years. And we know injury prevention programs are beneficial. Until recently, we haven't really had good data on how beneficial, because a lot of the studies were pretty poorly done. They didn't have controls. They were for different sports. A lot of different variables went into it. There's a new study out now on AJSM that really is the best one that I know of, that was a meta-analysis, looked at initially 2,200 studies that looked at injury prevention programs. They found 8 that fit criteria of being level 1 randomized studies with a good correction for multivariables and things like that, where the number of the power of the study went up significantly by that. And they basically only looked at these randomized controlled trials, and they whittled it down from 2,200 studies to 8 studies. However, overall, there was still 13,000 patients that they looked at in these 8 studies. And what they found was that the strongest evidence to date really is on the efficacy of the ACL injury prevention programs. Those are the ones that have been looked at the most. There's a bunch of them out there for ankles, for hips, for shoulders, especially in pitchers and throwing athletes. But the ACL is the one that has had the most studies on, and has gotten the most attention in research nowadays because of the prevalence of these injuries. And what they found in this analysis was that these programs, when done correctly, can really reduce the rate of ACL injury by 53%, which is a huge number. So that's any way you can reduce it is huge. But 53% of these athletes, if they can never have this ACL injury, that's a game changer. So by instilling a appropriate injury prevention program, which is typically done on the athletic trainers level in combination with the coaches and the athletes, is crucial. And there is no right, and I get asked a lot, I've given this talk a lot, I've given it to athletic trainers in Middlesex County, and they ask me, what is the program I should be using? There's no right answer. There's variation in all of these. However, they must adhere to these best practice standards, which we'll talk about. And that's really the crux of it. And this is really a position statement by the National Athletic Trainers Association saying that there's no one way to do an injury prevention program. It says, based on the available evidence, recommend a multi-component, so you got to include many things. Training include at least a minimum on feedback on proper exercise for at least 3 of these things, which are strength, plyometrics, agility, balance, and flexibility. If you read this article, which I'm sure you have, I mean, it's like 20 pages, and they outline all these different injury prevention programs and what they do for different sports, and it varies based on the sport, based on what's accessible to the athletes in the athletic training room, what's accessible to the school system. It also varies based on how involved coaches are and how involved coaches want the athletic trainers to be in these things. But really, it's a huge point of contention now, and something that should not be ignored, that these are beneficial and they will help prevent ACL injuries. The biggest risk factor of ACL injury is a previous injury of ACL. So, those patients who have had prior ACL surgeries, they're the ones that are at risk of these. So if you're not going to be able to instill an injury prevention program throughout the school, ones who should at least be focused on are those who have had prior ACL surgeries, not even in the specific knee. They're still at risk in the other knee as well. So, they should be for everybody, but at the very least, they should be in those patients that have had prior ACL surgeries. And these can be done in the preseason, throughout the season. They should be done, anytime, any practice circumstance that you're in, they should be incorporated. So I'm interested to see, one, if you guys have had much exposure to this, and how accepting coaches, high school coaches, were in discussing this and coming up with injury prevention programs. Can anyone speak to that?
A lot of our schools, it's in conjunction with, this is where athletic trainers can learn from strength and conditioning professionals as well, and collaborative PTs. Is we built this rehab, this injury prevention system that incorporates anti-rotation stability, mobility, and stability work, and movement pattern work in a progressive manner that then starts to build in some higher level plyometrics.
Good.
Because oftentimes, what a lot of the warm-up programs you'll see is they jump right into plyometrics straight away.
Yep.
They'll go right into the stuff that elevates your heart rate, but then they've got crappy ankle mobility, they've got crappy anti-rotational stability, and they're collapsing right away. And so we kind of took this approach of what are the most common areas we see breakdown in these injuries, and let's put them in as if we were prehabbing them on a regular basis. If you do it right, you can do it in 10 to 15 minutes. The key is coaches have to get buy-in
Well, yeah.
Because number one, they have to go through an experience themselves, but number two, you're taking time away from their practice. And to them, that's not what they learned. They learned it
Right.
differently before.
Yeah.
So we have to do our part to just build that relationship with them, to get them to trust it, to try it, and then experience it for themselves. And just me personally speaking, Ryan can speak to this too. It makes a big difference when you do that. Not only cutting down, hopefully cutting down the ACL stuff, but just patellofemoral problems,
Hamstring strains, yeah, everything. Yeah.
injuries. And it takes effort to do it, but the investment that you make initially to build that understanding with the coaches, to teach the captains, and then have the captains teach the team, it ultimately becomes a system, and then it takes less effort, and you're actually you're dealing with less stuff in athletic training because of that.
And what sports particularly have you been doing that with? Everything.
Yep, doesn't
Good.
matter. It's movement pattern specific, and it's
Good.
body specific.
And the coaches, for the most part, have been accepting of it?
Yeah, the schools are good working.
I know, just to speak, when we were working, when I was working with Ryan, we had a soccer team up in the Somerset area, their local high school. The coach came to us and was very concerned about, he had 5 ACLs the year before. And he was very concerned, and he wanted to take a step to try to be proactive and see what was going on. And we instituted a program, worked with them on the field, off the field in our center. I mean, educated parents. There was a whole
Yeah.
bundle that we put forward to them. And I mean, we didn't have one the year
Yeah.
after. They didn't have an ACL injury. I mean, they had other
Yeah.
type of injuries, but again, that specific type of program. So it goes back to speak to that study that you implemented a program like that. And it wasn't. We also added some things in higher level strength and
Right,
conditioning, which
yeah.
they didn't have access
Yeah.
to. But again, that core fundamental, making sure that the movement patterns were correct, make sure that they were able to control their body in certain ways, make sure they were learning how to decelerate, accelerate cuts properly. It all, once you get that foundation down, then you can go and
Right.
build up on top of that.
Which is great, because when I was in, which years ago, I mean, none of that was. This is a newer thing that people are doing, and I've been finding, because the first time I saw it was in New England, in Boston, with pro athletes. I mean, all right, they're pro athletes, of course they're going to do that. But then when I came back in here, I started covering teams around here. They were talking about it here too, and which is good. That's why these things are so important, that they get out there and people learn about them, because they are a lot more easy. Coaches and things like that are a lot more easily approachable with this. And that's where you can really impact and change the course of certain athletes, even careers, because you can prevent an injury like this, which 5-10 years ago was not even on the forefront. So,
I think a really big thing, not only with the prevention, because you're looking at right there, this is what they're recommending that we incorporate. Unfortunately, in my career, I've come across a lot of people who have ACL surgery, and they're not doing this stuff as part of their rehab.
Yeah.
And their rehab is not aggressive enough. I'm not saying aggressive in terms of stress to the graft,
Yeah.
but they're not being loaded early on in safe position. They're not working the contralateral side
Yeah.
hard, which the physiological effect of that is, uninvolved leg is training hard, doing single leg deadlifts and whatnot. You're going to get a crossover effect of neuromuscular activation on the other side, or the reconditioning part of it. So many times they're cleared by a doctor at, say, 6 months to start the cutting, but they have no foundation of capacity whatsoever, because
Right.
they haven't been doing anything. I think it's our responsibility as athletic trainers to work collaboratively with the PTs that are working with it too, because the PTs are only seeing them maybe 2 or 3 times a week. We're seeing them all the other times. That reconditioning component is so crucial, that working every other part of their body is so crucial, and we can't be afraid to push them.
Right.
We can't be afraid to get them going heavy with some stuff, as long as it's in a safe, controlled position based on, of course, the guidelines of the physician. Different.
Yeah.
You got a meniscal involved,
Right.
like stuff, but I think we as athletic trainers is something we can continue to work on in getting better at that, because sometimes we just hand off the rehab to the PTs, and they do a great job of it, but we also have a difficult time because of the volume of people that come into our room on a daily basis. We can't always do it if
Right.
we want to.
Yeah.
But educating and trying to find ways to do this with them is a difference maker.
Yeah.
When you get into that 6 to 8 month period, and they're still looking like there's these deficits, why are they still limping? Why can't they decelerate? It's because they've been so delayed in that neuromuscular re-education.
Yeah.
And that makes it difficult. And they get frustrated, they get
Right. Yeah.
The psychosocial aspect of it is big time too.
Correct. Yeah.
Yes, a lot of times I see athletes, they put so much weight on the bar and just trying to, this is before they even get injured, put so much weight and try and lift it. And they can, but you ask them to do a single leg RDL, and they won't hold it. They can't hold that. So why are you telling them to lift all that weight when they can't even stand on one leg?
Yeah.
And it just goes into, it's, I'm sure, I know a lot of guys at the forefront of strength and conditioning, they disagree that this is just good training,
Yeah.
let alone preventative training.
Yeah. So that's right. Well, good. That's good to know that this is out there and accepted. So just to conclude things, ACL, crucial optimal knee function, especially in pivoting sports. It is the second most common ligament injury in the knee, secondary to the MCL, but the most commonly operated on ligament. There are multiple risk factors. Some are modifiable, others are non-modifiable. Those modifiable ones are the ones that we should, and when we can, go after to try and minimize the risk of injury to these athletes. Graft and surgical technique are, in my opinion, are crucial to a positive outcome. It's not the only thing. You need good support. You need from the parents, from the coaches, from the athletic training staff, from the physical therapist, and a good patient. But you got to get this right from the get-go. You got to have all the appropriate diagnoses and address at the time of surgery in order to give the athlete a chance. Common injuries, like I said, must be identified and treated. And these injury prevention programs, which there's been so much research coming out on now, and sounds like great acceptance on all levels, which is great, because it wasn't there 5-10 years ago. It just wasn't really discussed much. Have been shown to dramatically increase or decrease the ACL injuries. And then these can and should be designed by the athletic trainers and incorporated with the coaching staff. And like you said, it's getting the coach also to buy into it and take up their practice time to incorporate that. But in the long term, it will keep the athletes on the field longer and minimize any risk of injury there. And like I said, can be utilized prior to season or during the season, or like you said, they're not just injury prevention, just good training mechanisms and tools to have. So that's all I have for you guys. If there's any other questions, now's the time. Yeah.
Is there anything out there right now associating like using treatments as far as like PRP in some of these cases?
The evidence that is out there for ACL reconstructions and ligament reconstructions have been shown not to have any significant impact. There is some research with combining cartilage studies with cartilage treatments with PRP that have improved outcomes. But as far as any ligament reconstruction, they don't do better when you inject PRP at the time of surgery.
Is there like delayed onset of, I'm thinking later in their life of osteoarthritis?
No.
That
What the studies are now showing in regard to osteoarthritis and ACL surgeries is you're going to get arthritis whether you have an ACL surgery or not.
Mm-hmm.
Even 5 years ago in my training, one of the things we said to patients in the clinic with ACL surgery is if you want to prevent arthritis, you should have an ACL surgery because you can get arthritis down the road without it. It's not true, right? Now we know you're going to, the damage that occurs to the chondrocytes is a shearing force that occurs to the knee that damages the cartilage then. You reconstruct the ligament to stabilize the knee, but that damage often is already done at the time of injury, and that can degenerate throughout the years whether you have ACL surgery or not. So these patients get arthritis, most of them get arthritis regardless of ACL surgery or not.
Always showed that study about 10 years ago, looking at ACL arthritis was minimized due to stop the progression. ACL reconstruction was the rate of 80% success rates in minimizing long-term.
Yep.
Yeah, so I actually had a patient who comes up with ACL not this year, but 3 years ago. And she actually had 6 weeks post-op. She had AMI, arthrogenic muscular inhibition. And I was wondering, as far as in your practice, have you seen that? And as far as treatment-wise, what would you?
That's a tough. So how did she present?
So it was on and off swelling.
Yeah.
And as far as she needed a revision in the end,
Yeah.
I unfortunately left the position, so I'm not sure for it.
Did she have any quad control or quad strength? Could she do a straight leg raise?
She could do straight leg raise if you help initiate.
Yeah.
And then as far as extension leg was there, obviously
So I have not had that happen. That's a horrible problem. It's a tough problem to deal with. There's not a good answer for it. In my opinion, and I think some of that has to do with nerve blocks. A lot of it has to do with swelling, for sure. A big swollen knee will deactivate the quad and then the surrounding muscles in it, and it's going to make it very hard to reactivate them. You get real aggressive with draining the knee, mobilizing it, trying to keep the swelling down, but sometimes it's a losing battle, and it's just swollen for a long time. I have seen patients of my own even that have had nerve blocks that I don't like femoral nerve blocks because of that continued quad atrophy, and there are studies that look at that even at 6 and 9 months there's much more atrophy of the quad than there should be, and there's a delayed onset of activation of the quads post-op. I've had a few patients who have gotten femoral nerve blocks unbeknownst to me that I thought they were getting adductor or sciatic nerve blocks, and I'm trying to figure out how the hell, 4 to 6 weeks they still can't do a straight leg raise. What is going on? And I go back to the anesthesia records. I see they got a femoral nerve block. That's the only time that I've seen that with that much muscle inhibition 6 weeks out. There's nothing we do for that. I've seen now 2 or 3 like that. The first patient I sent to a neurologist to see if there was anything we could do, and there was nothing. And overall, the 3 that I've seen have improved, but they're dramatically behind where they should be. So it's a horrible problem to deal with. It's a tough problem to address. Yeah, there's not much to do. Yeah, and then even if the ACL is still intact, revision, you're dealing with arthroplasty. You're dealing with it's a tough revision because there's not a good answer there. So luckily, I haven't seen much of that. The ones I've seen that are similar have been from nerve blocks that have all resolved, but the patient is behind where they should be because of it. Anything else? Okay.
Thank you very much, Doc.
You're welcome.